Hello, I'm Joe Bornoff. I am a PhD student in the Department of Mechanical Engineering at the University of Bath in the UK. And tonight I'm going to show my work, which is all about my PhD, which is the modelling the blood flow in a positive displacement artificial heart. This project is funded by the EPSRC and Scandinavian Real Heart and is undertaken at the University of Bath. So I just want to kick off by introducing the university and our research group, which currently includes 3 principal investigators, approximately 5 postgraduates and postdoctoral researchers, and a handful of MEng final year students year on year. So we're active in various British, European, and international societies. And we are involved with the university's Heart Hackathon team called Team Bath Heart, which is a student competition to design and build a novel artificial heart. And there are many universities around the world taking part in this competition. And we're set to fly to Dallas, Texas on Saturday for the 29th Congress of the International Society of Mechanical Circulatory Support, where Team Bath Heart will present their work at the Heart Hackathon final, and myself and colleagues will be presenting our scientific research. So the principal investigators in that team include Dr. Catherine Fraser and Dr. Andrew Cookson, who are my supervisors, as well as Dr. Lee Nissim, who has recently joined the department. Their field of work includes the study of hemodynamics of rotary blood pumps, computational modelling of cardiovascular diseases, and also blood pump optimization. So let's go on to my project and have a look at the background of it. So we should start by doing a little bit of recap for anyone who doesn't know about how the heart works. So the heart can be thought of as 2 parallel pumps that push blood around the body. The right side delivers blood to the lungs, which is known as pulmonary circulation, and the left side delivers it to the rest of the body, and that's known as systemic circulation. Each side has 2 chambers, an atrium and a ventricle, where the atrium pre-fills with blood that enters the ventricle, which squeezes the blood to pump it around the body. And the forward motion of this blood is governed by heart valves, one between the atrium and the ventricle, and one downstream of the ventricle. When looking at the left side of the heart, these valves are known as the mitral and aortic valves, respectively. So there are 2 stages to the pumping mechanism of the native heart. First is diastole, when the ventricle is relaxing and can fill with blood from the atrium through the mitral valve, which is fully open. Then the ventricle begins to contract, closing the mitral valve and squeezing blood past the aortic valve and through to the rest of the body. So the same pumping process occurs on both sides of the heart, but when we talk about pressure measurements taken around your arm, for example, we consider the pressures produced from the left side of the heart as these are greater and around the rest of the body. So the systolic pressure is the maximum pressure that is generated during the squeezing phase and is created because of the resistance of the peripheral vasculature in the body. And the diastolic pressure is the minimum pressure achieved during diastole and is reached slowly as larger arteries are also relaxing during this time, and this is known as their compliance. So when we get a pressure measurement at the hospital, say, it is these 2 measurements that are measured, for example, in this case, 120/80. Now, heart failure is when the heart is no longer able to pump blood in an effective way, either due to a buildup of fatty deposits in the arteries or damage to the heart muscles or any of the valves. And this can occur on either the left side or the right side, or to both sides of the heart. Now, heart failure is a global problem and affects an estimated sort of 64 million people worldwide in some way or another. Now, this can be treated with medicine or lifestyle changes, but for cases of serious end-stage heart failure, a heart transplant is the gold standard treatment. However, the heart transplant waiting list is growing and the number of available donors is limited. So what can we do? Well, doctors can turn instead to mechanical circulatory support to alleviate this shortfall issue. So what is mechanical circulatory support? Well, these are mechanical devices that pump the blood. and they can either be located inside or outside of the body. And for tonight's webinar, we're going to be talking about mechanical circulatory support that exists within the body. So different types of mechanical circulatory support is available depending on the severity of the heart failure that is occurring. So for single ventricle failure, which is usually the left side, the left ventricle, a ventricular assist device is prescribed. So this is a device that is implanted alongside the heart. It protrudes into the ventricle and assists the ventricle in pumping blood to the rest of the body. The pump is usually a rotary pump, either axial or centrifugal by its rotary means, and it normally produces a continuous flow rate, but recent studies have shown that by varying the rotational speed of the device, you can produce a sort of artificial pulse. However, when both ventricles fail, so both sides of the heart is no longer able to pump blood effectively to any part of the body. And in these cases, a total artificial heart may be required. So most total artificial hearts use a positive displacement mechanism to pump the blood, but there are a couple that use rotary means. And total artificial hearts differ from ventricular assist devices because they completely replace the entire heart. So the native heart is explanted and these total artificial hearts are implanted in their place and connected to the rest of the body. So total artificial hearts are currently only used as a bridge to transplant therapy. So in the time between waiting for a heart transplant. But research is being done into their use as a destination therapy, so chronic use of the total artificial heart. Now, currently on the market, the Syncardia total artificial heart is the only FDA-approved device. However, the Carmat ASIN total artificial heart has recently gained approval for sale in Europe and is undertaking some early feasibility studies in the US. So both of these devices are positive displacement devices, and they use either pneumatics or hydraulics to compress an artificial ventricle to pump the blood. But the focus of this study today and tonight is the real heart total artificial heart, and it's being developed by a company called Scandinavian Real Heart in Västerås, Sweden, which is near to Stockholm, and it's a novel 4-chamber pump. And it, like the native heart, has two sides, two pumps to deliver blood to the lungs and the rest of the body. And each side is comprised of an atrium and a ventricle, just like the native heart. So this pump is different to the previous described total artificial hearts because those pumps only have the single pumping ventricle per side. The real heart delivers a pulsatile flow, a physiological pulsatile flow, and the forward motion of this flow is governed by a pair of bileaflet mechanical heart valves, which are a type of prosthetic valve that are used normally in valve replacement therapies, but in this case they're used within the mechanical device. It uses a similar positive displacement mechanism to that found in the native heart, which I'll describe in a little second. And this aims to improve biocompatibility with the rest of the cardiovascular system. And this device is currently undergoing preclinical animal trials. And the aim is that this device will go to human trials in the near future upon completion of these animal trials. So we look at the principal pumping motion of the real heart artificial heart. So in the native heart, between the atrium and the ventricle, we can think of this as the atrioventricular or AV plane. And this actually translates upwards and downwards during systole in conjunction with the ventricle squeezing to pump the blood around the body. And it's actually shown that this upwards and downwards motion accounts for roughly 60% of the total stroke volume that is done during a heartbeat. So this is the mechanism that Real Heart have taken and used for their artificial heart. So this AV cylinder is connected to the atrium and the ventricle via a biocompatible deformable membrane. And this AV cylinder houses the mitral valve, which, as I said before, is a bileaflet mechanical heart valve. And this translates upwards and downwards, just like the native heart's AV plane. Now, the distance that this AV plane translates is known as the stroke length, and the rate at which it does this is known as the heart rate, of course. And the AV plane in the real heart translates downwards during systole and upwards during diastole. So now we're going to look at some of the aims of the project that we wanted to achieve within the PhD. So the principal aim is to investigate the hemodynamics and biocompatibility of the real heart total artificial heart using a numerical approach. And this aim was split into two main objectives. The first was to create an appropriate computational fluid dynamics or CFD model of the device. Now, computational fluid dynamics provides a useful insight into device performance, and it is cheaper and more ethical than in vitro and in vivo studies. It can inform the design and the operation of the pump to maximize the device's potential. However, with a problem as complex as this, it requires careful understanding of the underlying physics, as well as the appropriate choice of modeling approach and the methods that are used. The second objective is to use that model to understand what potential, if any, there is for any negative side effects, such as damage to the blood components. So blood damage minimization is imperative for a good quality of life for the patient, and in vitro tests are required for the device to be approved by regulatory bodies that investigate the possibility of blood damage. So in silico studies can therefore inform how best to operate the device, and if required, any design modifications that can improve the compatibility with the native cardiovascular system. This can reduce the number of future in vitro studies and in vivo studies, leading to lower costs and a quicker approval process for the device developers. However, for the blood damage side of things, it is not yet clear which approach is best when it comes to modeling the complex blood damage phenomena. And again, a thorough investigation into the appropriate models and methods will be required in this project. So first, we can explore some of the approaches taken by others to modeling artificial hearts, specifically those with a similar kind of positive displacement method of pumping, to get an idea of where to go with this study. So first, we'll look at the Syncardia total artificial heart. So this device has been on the market now for, since 2004, so almost 20 years, and has been implanted into approximately 1,500 people, providing roughly 600 patient years of support. And the most complex component of this Syncardia is a deforming diaphragm membrane, which separates the blood side, the ventricle side, to the pneumatics that contract the ventricle and pump the blood. So this study was done in 2014 by Maram et al. And some of the salient features is that they use dynamic meshing of the tilting disc valves, as well as a prescribed motion of the membrane to investigate the sort of membrane stresses, as well as the hemodynamics of the blood pump. However, this study really was only limited to the systolic phase, so the contracting phase of the cycle, and did not consider diastole, which is something that is important to do when you do these kind of studies. Moving on, looking at the Carmat total artificial heart, which is very similar to the Syncardia in that it's a single pumping ventricle, but this time it uses hydraulics rather than pneumatics to compress the ventricle to push the blood around. The Carmat has, as I said, only recently gained CE approval, I think about 2020, and they're moving on to sort of US studies to gain approval there. So this study from 2020 was done by Luragi et al. And it was a very complex simulation. They used a fluid structure interaction approach to modeling both the tri-leaflet valves that open and close, as well as the deforming membrane actuated by hydraulics to study the hemodynamics, the washout of blood, and the shear stresses that are experienced within the device. Now, as I said, this is a very complex model, and in the study was kind of limited to only a handful of operating points. So going forward, it's good to consider a range of operating conditions, because that's how the device will be operated in the real world. So there actually has already been one previous study of the real heart total artificial heart, and this was completed just before I started my PhD project. And in this study, Kelly et al. Used various different methods for getting the valve motion, appropriate valve motion modeling methods in the CFD model, and they determined which one was best. And in this case, using a prescribed motion of the valves, so determining the position of the valves at every time point from some in vitro analysis where they took a video of the valves opening and closing, was the most suitable method in this case, and it produced the most viable results. They used an immersed boundary method for incorporating the valve leaflets into the fluid domain, and it was all solved using Autodesk CFD. So this study was limited as it relied on that available video data from the in vitro analysis, meaning that the in vitro analysis had to be undertaken prior to the CFD, and they could only do those operating conditions in which they did in vitro. Additionally, there was a poor shear stress resolution around the valve leaflets, which is a limitation of the immersed boundary method and is an important factor to consider when doing a artificial heart CFD study, because as I'll show later, shear stresses are linked to blood damage. So using that initial study as the first basis of my PhD project, we're looking at the first study that I undertook, which would focus on creating a new valve motion modeling strategy where the motion of the valves would be fully fluid driven using a fluid structure interaction approach. So what this would mean is it would end that reliance on the pre-existing in vitro data and allow for a full variation in the input parameters of the pump, such as the heart rate, the stroke length, and other pumping waveform parameters. And also this new strategy would produce high quality shear stress capture in the vicinity of the valve leaflets, as this is important for the analysis of any future blood damage potential simulations. So this work was completed and submitted to the Journal of Computer Methods in Biomechanics and Biomedical Engineering and was published in April this year. So looking at the methods for this valve motion modeling strategy. So before creation of the full device model, this work would use a simple two-valve model that would enable a fast and efficient development of the fluid structure interaction approach. And this model was all developed within ANSYS Fluent. So starting from the full device, the key components were extracted, the mitral valve and aortic valve, and these were placed within a simple fluid cylinder. The mitral valve would translate upwards and downwards, and the aortic valve would remain in place, and both valves would open and close due to the fluid forces that were acting on them. And additionally, both valves would be rigid bodies, so they wouldn't deform. Now, the model was reduced down to a quarter model to improve the speed of the simulation with symmetry boundaries on the appropriate faces. And the main method that was used in all of this was an overset meshing approach. And this was done to incorporate the valve leaflets into the fluid domain. So we decided to go with overset meshing because it maintained a consistent and refined mesh around the surface of the leaflets, and it didn't require remeshing at each time steps when the valves moved. Instead, we would move the entire overset zone. So within ANSYS Fluent, the 6 degrees of freedom solver was used alongside a set of custom user-defined functions that enabled the motion of the valve leaflets. So the translation of the mitral valve was prescribed, and it was the 6 degrees of freedom solver that would open and close the valve leaflets. So additionally, a variable time stepping scheme was used where the time step reduced when the valves were moving, rotating fast. And this was done to improve the accuracy of the valve motion solution. So the main salient point from this whole study was a unique approach that was used to couple the motion of the valves to the fluid flow solution. So strong coupling, which is where the position of the valve leaflets are updated at the end of every sub-iteration within a time step, was implemented at points of instantaneous valve closure and opening. And this was done to enhance the stability of the solution at the cost of some computation time. So to improve the computational efficiency of the solution, weak coupling was therefore used at all other times of the solution. Now, weak couplings when the position of the valve leaflets are only updated at the end of every time step. So you could see anywhere from sort of 10 to 15 sub-iterations of strong coupling required at instantaneous valve opening and closure, whereas just the once per time step at all other times. So finally, a two-element Wing-Kessel model, which is it's a lumped parameter representation of the downstream vasculature, the compliance and the resistance of the downstream vasculature. And this was used at the outlet of the device so that a physiological pressure response could be obtained from the model. So just looking at the results for sort of a single case of this simple two-valve model at a total stroke length of 25 millimeters and a heart rate of 100 BPM, what we can see is that when the mitral valve is closed and moving downwards during systole, it pushes blood past the aortic valve, which opens it. When the mitral valve starts to move back upwards again during diastole, it draws in flow from the outlet, and this ultimately closes the aortic valve. And as the mitral valve is then still moving upwards and the aortic valve is closed, the mitral valve can now open. And at the point at which it starts to move back down again during the next phase of systole, the mitral valve can close and the cycle can sort of restart again. And this is the idea of a cycle, each heartbeat of this simple two-valve model. So this simple model was able to produce the results required, which were the valve kinematics, so the angular velocity and the displaced angle of the valves, the valve wall shear stress, the pressure distribution throughout the model, and the volume flow rate as well. And this model was shown to be a sort of a robust approach when there was a change in operating condition introduced in a quite small parametric study. But of course, these results don't really mean much in isolation. And so this method of valve motion was to be applied to the full real heart device, which is what we'll look at now. So the device that was chosen was a legacy device, the version V11C. And this was used in acute bovine trials. And we chose this device because there was a wealth of pre-existing experimental data that we could compare our CFD results to. This model that we were developing would allow for the variation in the heart rate and the stroke length, so similar to the two-valve model. And the data that we'd measure would be the volume flow rate, the pressure, valve kinematics, the shear stress distribution within the model, and also the washout of the blood. So this full device is a very complex problem, but the creation of this sort of simple two-valve model significantly eased the development time of the full device model. So this work was submitted and published in Nature's Scientific Reports and was also published in April this year. So April was a busy month. So this model would now include all the moving regions of the real heart, total artificial heart, the full device, which included a new overset zone to represent the AV cylinder that translated vertically and also housed the mitral valve. However, the deforming membrane that separates the AV cylinder from the atrium and the ventricle would not be modeled explicitly. Instead, all the parts were considered to be rigid bodies, and the membrane deformation, the shape of that deformation was approximated using the shape of the overlap of the AV cylinder and the sort of background mesh. So the methods used between the two-valve model and the full device model were pretty much the same. However, the algorithms that were developed for the two-valve model and used here were tweaked slightly to improve the overall efficiency and the stability. So the same overset meshing approach was used as described in the new AV cylinder zone. The Wing-Kessel outlet model was now tuned to the higher flow rates that would be generated from the full device. The blended weak-strong coupling was still used. However, more of the cycle was required to be strongly coupled. This was to improve the accuracy of the valve motion, and additionally the variable time stepping scheme was used, and that didn't need much in the way of tweaking. One change was that this time a hybrid polyhedral and hexahedral mesh was used, which used polyhedral elements on the surfaces to get a good approximation of the surface shape, and hexahedral elements within the bulk flow with a sort of transition between the two near the walls. This was found to improve efficiency of the solution because it improved some of the parallel partitioning, and mesh convergence was found with approximately 1.2 million total solve elements, so about 1.8 million total elements when including the dead cells of the overset approach. A K-omega SST turbulence model was used for turbulence closure, as when we calculated the peak Reynolds number that was found within the outlet of the device during peak systole, this placed the fluid in the kind of transitional and to turbulent regime. And for these sort of applications, it's shown that the K-omega SST model is best for these situations. And a cloud-based high-performance compute system, which was handled by the University of Bath, was used because there were many operating conditions to be simulated, and this approach using the HPC system allowed for many simultaneous solutions to be achieved. So the model was validated against a set of in vitro results, and this was done with the device placed within a hybrid cardiovascular simulator, which is a rig that comprises of fluid regions as well as a computational domain, and it's able to place artificial hearts within a loop of a blood analog fluid, and it can mimic the realistic physiological conditions that are found all within the body. But for this experiment, what we did was used a simple single resistance and compliance values. So we boiled down all of the compliance and resistance value within the hybrid cardiovascular simulator into one single value, and the pressure and the volume flow rates were measured throughout the loop. So to enable the validation of the CFD model and compare it to the experimental results, the parameters of the CFD model were matched to the experimental values, and a 40%, 60% systole diastole ratio was used. This means that 40% of the total cycle time is spent in systole, whereas 60% of the total time is spent in the diastole phase. The stroke length of the CFD model was derived from some diagnostic output data from the device during the in vitro experiments, and we're able to apply that in the CFD. And then the Wing-Kessel model that we've used was slightly tuned to include some of the sort of parasitic compliances that are found within the rig. So even though the compliance value was set within the hybrid cardiovascular simulator, this didn't account for all of the compliances that were present. So we increased our compliances in our CFD model just slightly to better match between experiment and simulation. So here are the volume flow rate results from the sort of parametric investigation that was done. So we varied the heart rate between 60 BPM and 120 BPM, and the stroke lengths were varied between 19 millimeters and 25 millimeters to produce a total set of 16 different operating conditions. And each condition was simulated for 4 cycles plus 1 additional cycle where some shear stress data was taken. And what we can see from these results is that the maximum flow rate increases as we increase stroke length and heart rate, so increasing cardiac output, which is in line with what we'd expect. And additionally, the mean flow rate also increases. The main thing to take away is that the results match very well between the simulated and experimental values. This is very well for our sort of field. You can see some variation in the experimental data, and I'll describe a bit later on why that might be, as the simulated data is a lot more smoother. But on the whole, very good matching between the two sets of data. And also looking at the aortic pressure. So the same operating conditions as shown previously, but now looking at pressure. Again, very good matching between experimental and simulated results. What this shows is that the mean outflow pressure, as well as the pressure pulse, both increase with an increase in stroke length and heart rate. And we can deduce that this is because of the Wing-Kessel model. So an increase in the volume flow rate now means that the pressure is also increasing in line with that. So we can take a 100 BPM heart rate and a 21 millimeter stroke length as a single example, and we can take a look at the velocity contour plots, the pressure contour plots, and the washout fields, as well as the sort of mesh motion that is obtained from the simulation. So looking a little bit at washout, it's an analysis method that uses an advection diffusion scalar transport approach. And what it does is it looks at how new blood is drawn into the device from the inlet and is expelled out of the outlet. And washout should be maximized because what it tells us is areas of stagnant flow, stagnant fluid. So if there are areas which has poor washout, this could indicate stagnation. And stagnation is a bad thing because it could lead to coagulation in the blood, which has many negative side effects. So the washout is measured between 0 and 100% inside the ventricle region in this case, and what it does is it displays a non-linear increase over time with these bumps, and over time, when because of the fixed boundary condition on the inlet, you'll see that the model tends towards 100% washout everywhere. So that's what it's going towards. What can also be seen is that the velocity fields behave much the same way that the simple 2-valve model behaved, but now you've got many more complexities to the flow field, thanks in part to the added complexities of the whole device as a whole. So one interesting thing that we can point out is that the valve leaflets of both valves actually close asymmetrically. So one valve leaflet closes before the other. And we can deduce this is because there is a difference in the amount of force acting on those leaflets during the closure phase. And this has been seen in some preliminary in vitro analysis done using CT scans of the device. And it's something that we can only obtain from a fully fluid structure interaction approach. That means that the valves open and close due to those fluid forces. So it's a pretty neat outcome from the model itself. So we look at now how that washout changes with the variation in heart rate and stroke length. So these 3 images show the scalar field for washout at the end of 4 cycles, and it can be seen that washout generally increases as we increase cardiac output. But to compare all of the different operating conditions, we first must normalize the washout by how long it takes to reach 4 cycles. Because we've got 4 different heart rates, each of these conditions take a different length of time to get to 4 cycles. And so by normalizing it, we can compare all the different operating conditions. And so this arrives at a normalized washout rate. And we can plot this against the mean volume flow rate or the cardiac output to get a better understanding of the washout behavior. So what this shows is that the rate of washout or ventricular washout increases with an increase in cardiac output. And what we can get from this plot is areas of improvement for device performance. So if we want to improve, we want to maintain the same cardiac output, so the same mean volume flow rate, we can see that there are a few opportunities shown here. Sorry. Yeah. So if we increase heart rate but decrease the stroke length, we can improve the washout of the device whilst maintaining the same average cardiac output. And improving the washout is beneficial, as described before, because it reduces the risk of stagnation and potential for clotting. Now looking at the shear stresses, these are analysed throughout the model. This is an important value in blood contacting medical devices, as elevated shear stresses correlate to an increase in blood damage, which has many negative side effects. So a threshold value of 17.5 pascals was used, and above this value, the volume of fluid that exceeded this value was plotted. So what can be shown is the majority of the shear stresses occur in the vicinity of the valve leaflets when the AV plane is translating at fastest. We can also look at the wall shear stress on the valve leaflet. This highlights that the areas that expose the highest level of shear stress are the leading edge of the leaflet in the case of the mitral valve as it moves upward through the fluid, or in the case of the aortic valve, the fluid moves past it through the outlet. So now on to how the shear stresses vary when we look at the heart rate and stroke length. Firstly, a volumetric average of all the fluid shear stresses were taken for each time step, and this produced a time varying value for each operating point. Then this value was averaged in time to produce a single value to compare operating conditions. And what we can see is an increase in this average shear stress value as cardiac output increases. So in the same vein as the washout, if we want to minimize shear stresses, which is something associated with blood damage, then we can use this plot to go some way towards this. And in this case, if we want to reduce shear stress, we reduce the heart rate but increase the stroke length whilst maintaining the same cardiac output. Now, just briefly, I want to showcase the computing approach that was used in this study. So this work was completed using some early access testing of the University of Bath's new cloud-based HPC system. And it has a vast array of different compute options depending on the task at hand. So the 16 different operating conditions tested would take a long time if it was solved sequentially. So the HPC system allowed for simultaneous solutions. The most cost-effective solution, if you're interested, was using Intel HC44 compute nodes, which use 32 cores per simulation. And the number of CPU hours for the solutions can be seen in the table, with 4 device cycles of pumping taking approximately 1,500 total CPU hours to solve, which is actually quite efficient when compared to other models of other artificial hearts. So concluding the full device study, the results of the full device agreed very well with the experimental data, and there was a smoother numerical response as the model had rigid approximations, and also the downstream and the upstream behavior was not modeled explicitly, which describes that smoother numerical response. When investigating the effect of heart rate and stroke length, washout and shear stress both increase with cardiac output. And if we want to improve the performance of the device regards these two parameters, then we can see conflicting advice is given. So improving washout means increasing the heart rate and decreasing the stroke length, but improving the shear stresses means increasing the stroke length and decreasing the heart rate. So there must be a balance required to achieve the optimum solution. So this model was found to be accurate and robust, and it can be easily transferred to different generations of the device, as well as other positive displacement pumps. The use of HPC resources also helped a lot in the model development and solving, and the results could not have been achieved without this use. So what's the next phase of work? Well, as stated earlier, the second aim is looking at blood damage and the likelihood of blood damage within the device. Firstly, hemolysis, which is the damage of red blood cells under fluid stresses for a period of time. So much so that the outer membrane of the red blood cells rupture and release hemoglobin into the plasma. And this can have negative side effects such as hemolytic anemia, meaning you're not getting enough oxygenated red blood cells in your blood around the body. And all blood contacting medical devices can cause hemolysis to some degree, as they all produce non-physiological flow. And therefore, minimization of hemolysis is imperative. This figure here can show how the plasma from an in vitro hemolysis test of a blood contacting medical device starts as a sort of clear yellow color, but over time this gets more and more red as the hemoglobin is released into the blood caused by hemolysis. The second blood damage that we want to investigate is thrombus formation, and this is also an issue in some blood pumps. And as I said before, with the washout, this can occur due to fluid stasis, where platelets within the blood, with stationary parts of the flow, are deposited on surfaces, and this starts the coagulation cascade, ultimately ending in a thrombus formation. This can detach and embolize and get carried around the rest of the body, which definitely is a bad thing and can cause many issues such as a stroke. So hemolysis is the current focus of my work, and we're working towards the specific aim of determining how hemolysis production varies with pumping parameters. So the main objectives of this work were to first experimentally measure hemolysis within the real heart, which has actually already been undertaken at the blood testing laboratory in Scandinavian Real Heart in Sweden. And what I'm going to do is, or I'm doing already, is using numerical methods to simulate hemolysis production using the existing CFD model that I've just developed for the full device of the real heart total artificial heart. And together, using the experimental and in silico studies, combining them to fully understand just how hemolysis production varies with a change in pumping parameters. And then the idea is to use these results to inform the design and operation of the device to minimize the potential for hemolysis. So the initial numerical work that I've been undertaking has focused on tackling the uncertainty on the methods for hemolysis simulation that has previously been developed for steady flow rotary pumps. So I'm taking these steady flow rotary pump hemolysis simulation methods and moving them onto a pulsatile transient positive displacement artificial heart. And these methods include Lagrangian particle tracking approaches, where kind of groups of cells are approximated as particles, and then the damage is integrated along their path lines that they take from the inlet to the outlet. So these particles are able to just propagate throughout the model and get pushed through during the simulation. Each cycle pushes more and more particles out, and we can get an idea of hemolysis if we average over all the particles that make it from the inlet to the outlet. Or there is the Eulerian scalar transport approach, where hemolysis production is considered over the entire domain using a damage source term that creates damage, and this gets propagated and transferred throughout the domain. So the main finding of these investigations will make its way out there soon, so be on the lookout for some future publications. So to conclude tonight's webinar, a novel total artificial heart is being developed by Scandinavian Real Heart in Sweden, and it mimics a key mechanic of the native heart, which is the translation of the atrioventricular plane. And my work has been to set up a CFD framework that can aid the device design and development. So first, I showed a method that I've developed for modeling the complex motion of the bileaflet mechanical heart valves. And this approach was showed to be robust and efficient, and it allowed for the full parameterization of the pumping parameters, ending the reliance on pre-existing in vitro data. This method was then applied to the full real heart total artificial heart, and some initial recommendation on the operation of the device has been made. And then finally, looking ahead to the future, blood damage modeling will be the focus of the rest of my PhD, and I'm aiming to simulate the potential for hemolysis and thrombosis within the device. So I'd just like to acknowledge my supervisors at both the University of Bath and Scandinavian Real Heart for their continued support throughout the project, as well as everyone at the University of Bath Research Computing Group for the early access to the HPC service and their continued help thereafter. So thank you very much for listening. Here are a couple of QR codes with links to the 2 papers that I've mentioned in this webinar, as well as a link to my LinkedIn as well. So thank you.
Well, thank you, Joe. That was really incredible. It's really nice to see the journey that it's gone on already and where it's going to go, and nice to have that really good validation with the experimental data as well. It's really impressive to see how closely that matches already.
Thank you.
So we've got plenty of time. We've got 10-15 minutes at the end here. If anyone has any questions, feel free to drop them in the chat, or to get going, feel free to unmute as well. Yeah, Ben, go ahead.
Thank you. Yeah, terrific content, Joe, and yeah, very well presented. So thank you. Yeah, I'm quite excited about this next stage of work, modeling the blood damage. I guess my first question is, do we know if the rheology of the blood changes with the amount of damage, and can that be modeled? And then kind of onto the modeling approaches, your Lagrangian approach, would that be a two-way coupled approach if the concentration of platelets changes the properties of the fluid?
Thanks, Ben. Great questions. So the first question being about the rheology of blood changing because of this blood damage potential. With regard to hemolysis, I believe that it doesn't change, and we can assume sort of steady values of blood rheology throughout the entire simulation, and it's what I'm going to be doing anyway. It's going to be assuming that these values don't change, as I've already started the work. However, that's just for hemolysis. For thrombosis, there is the potential. I mean, haven't seen it in this device, and I don't think it's going to be an issue. But if the thrombus does form, what you will see is a change in the actual fluid domain itself. So you go from having no thrombus to then this thrombus maybe growing, and from this the actual flow properties will change. So maybe not so much the rheology, but more of the computational domain. But I won't be considering that because I don't envisage the actual formation of proper large thrombi to change that. And then the second part of your question was related to the Lagrangian approach, and remind me, sorry, to do with the.
Yeah, I was wondering if it was a two-way coupled approach, or are you just interested in following kind of the journey of the particles and not their influence back on the flow?
Yeah, it is. It's a one-way thing. So it doesn't have any effect on the flow solution. These particles are meant to sort of. They don't really represent individual cells. They're more groups of cells, and how those groups of cells get affected by the shear stresses, because the size of the cells are so small. So we won't look at how the particles affect the solution. We're only interested in the path they take and the sort of shear stress history that they are exposed to. There are some studies out there which are quite cool that are starting to look at actually discretely modeling the blood cells themselves in the fluid domain and how they get moved around with a quite complex surface model of the cells and how they deform and stretch and group together, which is a kind of scary thought for this device with already how complex it is. But it's definitely a cool thing to look out for, and it might become more viable in the future.
Yeah, amazing. Thank you.
And take a.
See, there's a
question
from Robin.
Yeah, that's my dad.
Yeah. Hi, Joe. Yeah, great presentation. A couple of questions. You showed 5 periodic cycles in your simulations. How many cycles did you have to solve before achieving that 5-cycle periodicity? That's the first question.
Yeah, that's a good question. We saw to within about 5% root mean squared error that the final cycle was converged cyclically compared to the previous 4 cycles. It was done such that the first 4 cycles we kind of almost didn't consider for certain variables, and the 5th cycle is when we started to measure certain things. So the shear stress distribution was taken only on the 5th cycle because we had confidence that the 5th cycle would be sort of converged enough. So yeah,
understood. Yeah, thanks, Joe. The other question is, the total artificial heart has rigid mitral and aortic valves, leaflets, and you indicated that the shear stresses associated with the fluid flow around those were the major contributors to blood damage. Now, in a real heart, those valves are elastic. Yeah, they change shape based upon the flow. Might it not be a good design consideration to imagine more flexible valves so as to reduce that shear stress and therefore minimize blood damage?
It's a good question. So the main thing to consider is that these valves that are used in the delineating between the real heart and the native heart is something I'd struggle to do. So I've stuck to saying native heart for the one that's found inside the body.
Right.
the bileaflet valves that are used in the real heart, total artificial heart, are ones that have been studied extensively in use of valve replacement therapies, and the conditions that those valves experience within the native heart are very much the same as those found within the real heart, total artificial heart. So there's less of a concern about how much they're going to be damaging the blood, because it's something that's already well documented in valve replacement therapies. When it comes to other valve options, there are bioprosthetic and prosthetic valves out there that have flexible leaflets. There are a couple of issues that these present over the bioleaflet valves. The first one is durability. The bioleaflet valves are much more durable and can withstand any sort of large pressure transients that may occur or may not occur. And there's less likely that they're going to tear and require sort of further assistance down the line. The other thing is that these bioleaflet valves have been designed specifically to reduce the possibility of stagnation of flow. There's a pretty clever hinge mechanism that allows blood to always pass it and wash it out and get rid of any stagnant areas of flow. And so for that reason, they're a pretty viable valve option at this stage. But it's something that could be considered down the line. I'm sure it's something that the company will may think about, they may not think about, because it's showing to be okay right now.
Lovely. Thank you, Joe. Thank you.
No worries.
Great. I think we've got another question from Tuan.
Tuan?
Hi, Joe. Sorry for not being able to show my video, but my internet connection is
okay.
Thanks for the lovely presentation. It was very clear. I have one or two questions. One is a bit continuing on the valve thingy, because you indicated that the wall shear stress you measure is considerably, how do you say that? Causing the hemolysis to become worse, kind of, or causing hemolysis. Let's put it that way. But the part where you measure very high wall shear stress values is very small. So in essence, not so much blood comes in contact with maybe the trailing edge. I don't know. What's your view on that? Do you think it's then very affecting this problem? Or?
Thank you, Tuan. That's a good question. In this model, it was generally shown that the high shears that are generally associated with hemolysis, which is anything kind of above 150 pascals, so the very sort of top end of the shear, the total volume of blood that was actually experiencing that shear was very low. And from that, we can deduce that the possibility of blood damage from the motion of the valves and the overall bulk flow properties is very small. I should probably make that clear, that we've highlighted that this should not be an issue in its current stage. The future blood damage simulations are aiming to kind of improve fidelity of the model and work towards a better understanding of hemolysis production within the entire sort of around the valve leaflets. But I haven't yet finished that work, so I'm sure I'll present it at some point.
So it's less focus on the peak values in that sense, and more average.
Yeah, it's
in a way.
Yeah, it's a twofold thing, hemolysis. It's the elevated shear, and it's also how long that shear is experienced. Yeah. And it's generally shown or found in this full device model that those two factors were pretty small, and so the possibility of blood damage is pretty small.
Great. Then I have one more question regarding the particle trace or the tracking of particles. Is that something you did after the simulation? So after you achieved or obtained the velocity field, or is it something you already implemented in the solver itself?
So currently it's implemented alongside the fluid flow solution. The two are solved simultaneously. The reason for this was that the model has now become the latest generation of the device. The mesh size has increased dramatically to resolve some finer details within the model. And what this means is, because you need to save the flow field and the mesh files at every single time step, and if you wanted to then do the Lagrangian tracking on top of that, you're dealing with a very large data set, which is unworkable in its current framework. And so it's found that doing the simulation of the particles at the same time as the flow field and not having to worry about exporting sort of case and data files was an easier approach at this stage.
Yeah, that makes sense. Thank you for your answers.
Great. I think we have time for one more quick question if there is any. Anything that someone wanted to ask? If not, I might sneak one in. I was interested in the asymmetric movement of the valve leaflets, and nice to be able to see that matching between your simulation and the kind of what's being found in the actual implants. The question is whether that's a problem. I can imagine that would be contributing to increased shear. And if it is there a design solution that then gets implemented off the back of this better understanding that your analysis is able to provide?
It is. It's a great question. Tiptoeing around saying things are bad or anything, but I don't think it's a massive issue. To improve it, which is not something that we've actually looked at sort of how to sort of do yet. To improve it, you'd probably want to start to increase the sort of the symmetry of the geometry that is upstream of the valves. If you do that, then you're much more likely to have a symmetry of forces that are acting on the valve leaflets when they close. In this model for the V11C, there's actually a side inlet which contributed to some of the asymmetry, because it contributed to an asymmetry in the initial flow field, and so further down this had sort of further ramifications. But in terms of the actual differences in the sort of closing velocity, they're still pretty close to each other in the sort of ultimate closing speed. And so it didn't really have a massive effect on the sort of shear that was being seen. And even if there was a shear, it was dissipated very, very quickly because once closed, that shear was not experienced anymore. And so for things like blood damage, it's not a big issue. But maybe for valve durability, it could be something that could be looked at in the future. But as stated, these bileaflet valves are already known to be pretty durable and shouldn't cause too many issues.
Yeah, that makes complete sense.